Welcome to the CereCore Podcast, where we focus on the intersection of healthcare and IT. From practical conversations to strategic thought leadership, let's unpack the decisions, challenges, and journey of those whose purpose it is to deliver technology that improves healthcare in their communities. Today, we are honored to welcome Sir David Sloman to the CereCore Podcast. Sir David has devoted over 40 years to the UK's National Health Service, serving in senior leadership roles at the hospital, regional, and national levels. Most recently, he was Chief Operating Officer for NHS England and previously led as NHS London Regional Director. His career includes more than a decade as CEO of Royal Free London NHS Foundation Trust, among other hospital and primary care leadership posts. He has guided the NHS through transformative change, including navigating successive waves of the COVID-19 pandemic, and has been recognized with a knighthood for his services to the NHS in 2017. Today, he continues to influence healthcare globally as a senior advisor to companies such as Siemens and Jacobs, and as a visiting lecturer at University College London and Imperial College London. Sir David, welcome to the CereCore Podcast.
So, Philip, it's great to be here. Thank you so much for inviting me, and I look forward to chatting. I look forward to talking.
Yes, indeed. Now, this is going to be a special one, just given your breadth of knowledge, not only in the UK but also around the globe. So, Very interested to get into that a little bit here.
Sure, that'll be fun.
Excellent. Well, for our listeners, David, that might not be familiar with your background, could you share just a little bit about your journey in healthcare, maybe some of the roles that you have held with the NHS and internationally, and really what drew you to healthcare in the first place?
Sure. I'm very happy to share, Philip. And what I will try to do is not repeat the very kind and generous introduction you gave me, which is greatly appreciated. But where you're right, in September 2023, I retired after 40 years worth of service in the NHS. So I joined in September 23 and left 40 years later in September. And I'm sure there are people who are listening to this who weren't even born when I joined the NHS. It's that long a shift that I did. And I loved it. I enjoyed every second of it. And I was incredibly proud of contributing. It's for others to judge whether or not that contribution hit the signs, but nobody to say I didn't turn up and work hard and try. As you said, my last job in the NHS, I was the Chief Operating Officer of the NHS for England, overseeing the performance of about 165 hospitals and mental health trusts, about 39,500 family physicians, GPs as we call them, with shared corporate responsibility for a budget of about £175 billion, covering around 56 million lives. So it was a substantive job. And that was after I did the London job for a number of years, which was a similar role covering about 10 million lives within a £20 billion budget. And as you said before that, I was the chief executive of the Royal London NHS Foundation Trust, we call it, which is a big, large teaching hospital in the north of London, where we were part of University College London Academic Health Science Centre. So it was a big London complex teaching hospital. And while we were there, we were accredited actually as a global digital exemplar by the NHS. We built what was and is the most digitally enabled hospital in the NHS, which was it was a fantastic experience. We were privileged to have had that opportunity. And we were early on starting to experiment with how we put AI to work in the NHS. So we're taking the early steps. Since then, I've now, in the last couple of years, I've developed a bit of a portfolio career. I'm on the board for AXA for UK and Ireland, which is a major insurance business. I'm the vice chairman of Spire Healthcare, which is the second biggest provider of private healthcare in the UK. And I do some global work, as you say, with Boston Consulting Group as a senior advisors and others. And I am a senior advisor on the IHI. So it's been fantastic. I mean, it's really interesting. And coming back to your question, why have I enjoyed it so much and what's brought me to it? I think there are two things, actually. The thing about healthcare is it really matters. It really does matter. And the second thing about it, it is just incredibly complex. And I
Very
think
true.
what curious people enjoy are really complex things that really matter. And that's what's constantly motivated me throughout those, more than 40 years, because I'm still going.
Yes, you are.
I'm not going to stop for a while. So
you're not slowing down either.
No, and that's going to be my story to date. And I've never lost my passion for that, actually. It really matters. It's really complex. And so it's exhilarating. It makes you curious. And it makes you want to try and improve things just a little bit and move things on just a little bit further.
Oh, that's absolutely brilliant. No, I appreciate you sharing that. And, it always fascinates me to hear the stories of how folks, got into healthcare in the first place and then what kept them there. And I think just those two components there are brilliant. And I think certainly very, very well stated. And, you talked a little bit about just that expansive experience, not only from a UK standpoint, but also internationally. And so, maybe tying into some of that experience, healthcare is facing a myriad of challenges today. And perhaps, regardless of geography, what do you see are some of those common challenges, regardless of what country you happen to be working in?
So I think you're absolutely spot on, Philip, actually. Wherever I go, wherever I work, whoever I talk to, broadly speaking, there are 6 global challenges which everybody is grappling with to a greater or a lesser extent. The first one is about the rise in demand, increased demand for healthcare services. And that's as a consequence of 2 things. Is firstly increased life expectancy. We're living longer. Certainly in the UK, between 1961 and 2021, life expectancy in the UK increased from 70.9 to 80.7 years. And that's a phenomenal achievement when you see. Now, I always use 1961 as the benchmark year, Philip, because that's the year I was born. That's when it all started there. So,
we all have to have that anchor benchmark, don't we?
We do, don't we? So, and the second thing, of course, that is compounded by the increase in morbidity associated with lifestyle. Obesity is the obvious one to point to, but and you put those 2 things together, and globally that is really increasing the demand on health services. The second thing alongside that is, of course, the relentless march of technology, new drugs, new medicines, new therapeutics coming out of the pipeline, which brings us to the third global challenge, which is patient and public expectation. They all want all of those new medicines, all of those new therapeutics, and they want them right here, right now. So it's patient and public expectation. And there's another element to that, actually, which is about the retail offer. So I think people want them right here, right now, on my terms. And I don't want to have to fit in at the convenience of the clinic or the hospital schedule. I want it all about me, actually. And if you compare the way healthcare has responded to that change in customer or consumer expectation compared to banking, we're behind. We're just behind. We're behind in that space. So the next challenge is, of course, the global workforce shortage. I think the World Healthcare Organization around the world has suggested whether they're going to be short of about 10 million healthcare professionals by 2030, which for me, so that will be the biggest internal disruptor. I think we have a model of care which is predicated on a workforce supply chain that actually isn't there. So that it's just there. The fifth one is, and again, this is again genuinely global, is post-COVID recovery. Health services have been slow to get back to levels of productivity that people were performing at pre-COVID. Certainly in the UK, there's a real productivity challenge with doctors, nurses seeing about something like 20% fewer patients than they were pre-COVID. Yeah, and it's 21% in Finland, 16% in Canada. This is not, again, it's a UK issue. There's the whole post-COVID. And final thing, if you put all of those things together, is how does a nation afford a healthcare service for its citizens? Now, to a greater or lesser extent, Philip, everybody is grappling with those 6 challenges. And as far as I can see, nobody has cracked it. We're all trying to learn and find our way through, but those are the big global challenges.
Yeah, no, those are, I think you're spot on there. And it is interesting, having looked at, across, and you've been a part of a number of these.
Yeah.
I'm interested to get your take on the why around the slowness of the recovery post-COVID from a volume standpoint.
Yeah, it's a good question. So I don't think anybody knows the answer to that question, actually. But the one thing I would say is the delivery of healthcare services often does rely on discretionary efforts and people going over.
Yes.
So they will go over and beyond, because by and large, the people that join the healthcare industry are compassionate, caring people who want to do the best for their patient. And they will slip another one on the list, and they'll go a little bit further and they'll go a little bit more.
Yeah.
But I think societally, people have taken a big step back after COVID, and those issues about the work-life balance have come more to the fore, And the other thing is, if you look at the occupational absence from work for mental health reasons, has seen a material increase post-COVID around the world. So I don't think it's just about health. Certainly, if you look, some of the work I do with some of the companies in the city, they're struggling to get people back into the office. They'll come back there too. So is this all part of the same thing, Philip? My instinct tells me probably. It's a different world order, I think.
You can draw a logical conclusion, a correlation there for sure. And, certainly that's one of the things that I think I always think about in the context of, the health system there in the UK is very different than the healthcare system here in the US. However, there's some similarities.
There are.
In those challenges, again, getting folks back in the workforce, and what is that, not only in the workforce, but also just in the office, and then having that human interaction in a day in and day out basis. And what has that meant to mental health? And I think it's one of those things that, time will tell.
I think that's right. We don't know, do we? We don't know yet.
No, we don't, but we're seeing hints in the market, right? And we're seeing hints with where, where those charges are coming from, where people are presenting. And it is a challenge, and we are in a new era, and
we are.
I'm not sure we've got an answer yet for it.
Well, some people would argue that we're actually in year 6 of the global pandemic, and this is what the 6th year looks like.
Yes. Well, then it's an interesting time, to say the least, right?
Yeah, it is indeed. It is indeed. It is indeed.
So maybe so we've got the challenges. Maybe we pivot a little bit and talk about perhaps some of the innovations. You talked a little bit about, tech and that, and the adoptions, or, innovations, maybe even strategies or so that the systems are using, regardless of UK, US, or elsewhere, that are driving improvements, that are driving efficiencies.
Yeah. Okay. That's a great segue in. So in the UK, and I'll just use the UK and then I'll lift it up. There's a very, very senior, experienced, and I think internationally well-regarded surgeon, politician, leader, Lord Aradazi. He wrote a report about the NHS and what he thinks that we need to do to address these issues. And he talks about the 3 shifts.
Yes.
And those 3 shifts are the shifts from sickness to prevention, from hospital to community, and the comprehensive shift from analog to digital. Yeah. So those are the shifts. Now, I could be cynical, Philip, and I could say that when I was training 40 years ago, the shifts we needed to make were from sickness to prevention, from hospital to community. But my big argument would be, those days we didn't have the data, the data mining skills, and the digital channel shift opportunities, and also the drugs and therapeutics to enable those things to happen. And so, as an eternal optimist, I think this might be the time to make those big shifts. Now, again, although I'm talking about Lord Darzi and the Darzi report, again, these are really generalizable. All healthcare systems are looking at, how do you shift from sickness to prevention? How do we give people more agency? How do we encourage people to make greater use of greater looking after their own health?
Yes.
Now, there are things that we're all doing already. Now, but the story I now tell is 6 years ago, not everybody knew how to stick something up their nose and waddle it around and put it on a piece of plastic and tell if they had an infectious disease or not. And that now everybody knows how to do it globally. We know how to do stuff at home that we didn't do before. So there's some quite breakthrough moments there, actually. I think, I think we underestimate that. Actually, the behaviours we learnt in COVID are behaviours which we now have become accustomed to about home diagnostic, home testing, shifts to care at home. So on the prevention stuff, I don't know about you, but every day I'm looking at my watch, looking at how many steps I've taken. I'm looking more at my own health. I'm now used to curating my own data on my app, on my phone. Yeah, so all this primary, and I think I led the COVID vaccination program for London, and London's a population of 10 million people. It's twice the size of Norway, is how I always describe it. So it's kind of a nation state. It's got a very, very complex population. It's about 42% are from black and minority ethnic backgrounds. It's 5% younger than the rest of the UK, and it churns. It doesn't move. It's like servicing jelly, is how I always describe it.
That's a great analogy.
But this time around, we had the data and the data mining skills to know how to really target those interventions to communities that we got to that we never got before. The other thing I learned, Philip, actually, was the importance of faith leadership in getting into some of these communities. So I think we've got some medicines, and we've got some data mining techniques, and we've got some this is population health management, isn't it? Is what I'm actually talking about. To really get into that. And of course, we've got just as big an opportunity in the secondary prevention space, arguably a greater opportunity than in the primary prevention space, to really stop disease progression and not just, not just prevent disease upstream. The second thing is the shift from, hospital to community. I had struggled for years of my career to see, could we get people having their outpatient appointment done virtually rather than trekking into the hospital? And suddenly, within 3 weeks, we were there. Woof.
That's right.
As you say. And also we opened, in the NHS, I think, just over 12,500 virtual care beds where people were cared for in their homes.
Right.
Using remote monitoring technology, basically some very cheap white disposable, white goods sent to people's homes. They're tracking their stuff on their phone. They're much happier. There are fewer complications. And as you and I both know, Philip, if a person is admitted to hospital, particularly someone who's older, it is often the gateway to long-term institutional care at great societal cost. So, the societal benefits of these models. And as I say, this stuff is there. It wasn't there before, and so I think there are, and again, globally, people are really looking at what this, and of course, I don't suppose we should end this conversation without using the word or the letters AI, should we? I suppose we have to.
Probably not.
So, but I think there will still be some efficiency stuff in there, won't there, about back office processes. I think the ambient voice technology stuff really does look like it could make a clinician's ability to perform at the optimum of their potential, the top of the grade, we say over here. There's bound to be stuff in there. So I think, as you can see, I am an eternal optimist. So I think this is a really great moment to embrace this stuff.
I absolutely love it. And, it's been fun to watch the journey of transformation over there in the UK, compare it against the US, and see how different models work based on a number of factors, right? Certainly reimbursement, how healthcare is paid for is a huge driver in some of the delta and some of the changes in that. And then also, you mentioned, the use of AI and ambient and all of those sorts of things. I mean, bottom line is, everyone here from a U.S. perspective looked at ambient and said, this is great. The doctors can see more patients, and therefore we're going to have more throughput and all that. And so we're going to implement ambient. Great. Well, that's not what happened, right? The output was such that, hey, there was a couple of things. One, you got to have more face time and interaction with the patients, which was a more personal thought process going on there. Secondarily, the notes were a lot more thorough. The documentation was a lot more thorough, which led to things not getting overlooked or missed after the fact. And then third, and this is interesting, was every single physician talks about cognitive load.
Yeah.
And they all said this reduced the cognitive load that we carry on a day in and day out basis. And so the adoption's been tremendous in the States. The outcomes, very different than what was predicted, but no less beneficial. And I think that's the fun part about what's occurring with us right now from a healthcare standpoint with technology, is that we are seeing those benefits. They might not be the ones that we thought we were going to see, but benefits nonetheless.
Absolutely. I mean, I'm old enough to remember when we started implementing computers.
Yes.
So we have to go back at the day for computers were going to replace jobs. There will be no jobs left. It's all going to be my suspicion is it's exactly as you describe it. It won't play through in the way that we think.
Of course. But again, it's the leaders of the health systems have to be flexible, right?
Absolutely. Yeah.
As we move forward. So, I know we've talked a lot about what's going on, some of the things that, that are transforming from a healthcare perspective. Let's talk just a little bit about leadership. So, and you've made mention earlier of the fact that there's been some churn. Certainly a lot of folks leaving the workforce that have been in and around for a period of time. But leadership, as we all know, right, it drives the culture. It drives that workforce. Maybe talk a little bit about some of the shifts that you're seeing with regard to that in the NHS and elsewhere, and some of your thoughts about that.
Yeah. So what I would say, there are some things which I think remain constant. Yeah. So I think the leadership challenge in healthcare is always about three things. Actually, it's about remaining relentlessly patient focused. Yeah. And I would kind of change that sentence now as we move into population health stuff to remain relentlessly patient and citizen focused. And probably citizen and patient focused in that order is probably the way I would potentially, we'll still have to look after individual patients, but thinking about cohorts of populations and populations of patients, I think will become more important, actually. The second thing, and you'll be shocked and surprised to hear me say this, given what I've been saying so far. The next thing is you need to be eternally optimistic. So as a leader, you absolutely need to be optimistic and paint the picture of those uplands, because what we do is hard. Yes. Health is hard, actually. And as leaders, we have a responsibility to give that optimism, to paint that future that we will be leading people towards. So I think optimism is really important, and that hasn't changed. True. And the third thing is about making decisions and doing difficult things. So, and you got to call it sometimes. You got to call it, and if you're the boss, your job is to call it.
That's right.
And actually, it's kind of easier not to, but you got to do it. If you're really going to make the progress, you've absolutely got to do it. So I think those are things that are confident or remain constant. But the other bit I think more about now is the importance of humility. I think realizing as a leader, actually, that we haven't got all the answers.
Right.
That we need to listen. And I think there's two sorts of listening. There's listening because you're waiting for somebody else to stop talking so you can start talking. And then there's actually listening.
Yes.
When you're actually trying to listen to what people. So I call that leading with humility. But the other side to that coin, again, for me, is the importance of conviction. It's you should demonstrate humility and conviction when you've listened, when you've thought, when you've brought those views to the table. you then do need to call it, make the decision, and lead with conviction.
Yes.
But I think that is I think the days of the heroic leadership. I think we've moved through, and I think, and I welcome it. I welcome that more inclusive, more democratic approach. But you still need, at the end, to make the call and lead with conviction.
Indeed. Because otherwise you're stuck.
Yeah, that's right. Yeah,
analysis paralysis, which is
and there's
never
nothing
a good place for anyone.
Yeah, and the other thing I think is, well, when you make that decision, the only thing you do something, it goes a bit wrong, you put it right, and then you do the next thing. Because the only thing you know is it'll go a little bit. I implemented an EPR, actually, a big, electronic patient record system in the hospital. Before, one of the last things I did, actually, it was the second time I'd done it, and I was at my board, and the board meeting said, "Right, David, you've answered this. Can you guarantee me that nothing will go wrong?" And I said, the only thing I can guarantee you is I'll make a totally different set of mistakes to the ones that I made last time around.
That's brilliant.
Well, it's the truth, isn't it?
Indeed. I think that's great. Yeah. So, yeah, you brought up EPR, and I know certainly the NHS has been undertaking a significant digital transformation, putting a lot of effort into that over recent years, and so perhaps enlighten our audience from your seat, from your perspective. What are you seeing as some of the key takeaways of that journey for the UK?
Right. I think in terms of what I've learned, if you like, what I've learned about implementing EPR is, firstly, do not underinvest upfront. Yeah, and of course, the EP, at the end of the day, it's a load of software and hardware. That's not going to drive the improvement. It's going to be the people and the processes and the changes in the way that you do things. And then it is about how you codify that into your workflows to make the delivery of care effortless for the clinicians and the patients. And I think where I've seen it go wrong is when they haven't involved the clinicians up front from the get-go. You need the clinicians at that table. Clinical leadership is key to this. That you undertrained, that you think it through. So really putting the investment up front. If you don't invest properly up front, you will repent at leisure. It's just worth putting it up front. The second thing I've learned is, if you're really unlucky in your career, you have to do this once. Yeah. So get some help from people who've done it before. Yeah. Right. So, there are organizations out there. There are people who can help you, seen there, been there, seen it, done it. They know they can hold your hand when it goes a little bit wrong. And it will go a little bit wrong, by the way, is what I'd say. And what I said to my team when we were implementing that EPR, I said, I will judge you all on one thing, which is how we behave when it all goes wrong. Because that is actually that's when the rubber hits the road. How do you behave when it all goes wrong? The other thing I've learned, and is when I first implemented an EPR, I thought go live was the cup final. That was Super Bowl Sunday.
Yes.
And once we got that done, it's all over. That's the beginning. That is the beginning. That means you're out of the qualifiers. You're out of the qualifiers and into the real work starts then. Yes. So really driving out that return on investment. Yeah, of course, have a party when you go live, because it is a big moment. There's a lot of work there. Put up the bunting. But that is not the cup final. That's you getting out of the qualifying rounds, and the hard work starts there. So those are my big learnings. Invest up front. Yeah. Get some help from somebody who's done it before. Yes. Yeah. And remember, go live. It's what I call it's the end of the beginning.
Yes. That's right.
Because then you start leveraging. Then you start, and as I say, it'll go a bit wrong. But the other lesson I've learned in life, if it doesn't go a little bit wrong, you weren't ambitious enough. No matter what you're doing, it's aim high.
I love that. It is interesting because the software vendors want to, the pinnacle is go live. right? And they'll say, "Oh no, it's going to be great, this, that, and the next thing," because they want to get the sale. They want to get things moving, and there's nothing, something to be said for that. But I think you're spot on with putting in the work up front, especially when you're going to a fully integrated EPR. Off of, let's just say, another 30 systems or whatever that didn't necessarily talk, right? So all of a sudden, decisions that used to be made in this silo can't be made that way. They have to be made in connection with the entire workflow. Yeah. And so putting that work up front makes all the difference in the world, saves a lot of rework on the back end, and certainly leveraging a group that has seen it before a time or two makes a big difference.
It's a huge difference. It's quite interesting. I had the great misfortune of 1 month ago today, I stepped into a metal band that was loose on a pavement, and I lassoed myself and went down on my elbow and smashed my elbow into 4 pieces. And so I ended up in the ER of a very good hospital in central London, and the nurse saw me, and she was using the EPR to look at the X-ray on my hand, and I said, I won't give the brand name. I said, "How is this for you?" And she said, "It's been in 2 years now." She said, "When it came in, I hated it, but it's great. It's fantastic. It's changed my life." And and this was an old stager. This was somebody who'd done a shift.
Yes.
And and the consultant was standing next to her, smiling. Actually, it was a great little story, but it brought it back home to me. It's the work starts then. That work on optimizing the investment, getting your return on investment, and it never stops. Actually, my general view is it's the journey, as they say, is never ending.
Well, let's talk about that never ending journey. So. And I'll ask you to kind of put on your forward thinking lenses. So as you look towards the future, from a healthcare standpoint, what are the trends? What technologies do you believe are going to have the greatest impact on health systems globally?
Yeah. So I point to a few. I think. However you want to dress it up, there's lots of different people talk about this in different ways, but genomics and precision medicine is clearly going to be profound. And as we start to get a better understanding of people's predisposition to disease, predisposition to illness, our ability to intervene right up front and keep people well, either present the disease from occurring or at minimum slow down disease progression, I think has got enormous potential. And our ability to curate data at meta-population levels to do that is really, really exciting. Now, the other side to that, Philip, is I think that's not going to come cheap for a while. And one of the things we have to think through is how we don't perpetuate what are already quite profound inequalities in access to healthcare and life outcomes and longevity. We need to think through how we actually service. But I think that genomics, precision medicine is going to be big. The next thing is I do think globally there will be a much greater expectation on people taking more personal responsibility and having more personal agency for their health. Yes. And I do think more of this will be tech related. I come back to, we all learned how to test for COVID, didn't we?
That's right.
I along with a lot of people now know how to take my blood pressure daily. And I think, and the great thing about that is I'm a great believer in the nudge stuff. I'm competing with myself day in, day out. Yes. For those extra 200, and you realise that I'm a sucker for it. It's really interesting, the psychology of it all. So I think that an expectation that there is more agency as both an individual, as a patient, as a citizen, but also probably as an employer. I think we will look at what is the role of the employer in supporting people to stay both mentally and physically healthy in the workplace, I think is going to be another trend that we will certainly see more of. And then the final, I won't go on to what will be the relentless march of new medicines, new drugs, new therapy. If we look at what the obesity medicines are potentially done, and we don't really know what all that can do yet. There's kind of I think that there's more to come in that space. But then the other generic piece will be, I think, the digital channel shift. I think we will end up receiving more of I think that will vary on. I think by and large, I always talk about a polemic between people who place a premium on convenience and access and those who place a premium on continuity of their care. Now, I'm on a few repeat medications. Frankly, I don't care who I see. I just want to order it on my app, and if I want to order it at 6 a.m. or 11 at night, I don't need to see the same person. I'm assuming somebody else is making sure that the medicines are regulated, that that's all being looked after. Indeed. On the other hand, my mother had the good fortune. She made it till 96. She had a good innings, my mum.
Wow.
But at the end, of course, for her, continuity was more what mattered. Seeing the same people. So if we can free up our clinical teams to offer continuity to the more complex, multi-morbid people, while people down here are getting most of their stuff through the digital retail offer, which they're used to in their other lives around shopping or banking or whatever it is. I think those trends that, again, globally, healthcare is heading that way.
Yes. No, that's fascinating. And, certainly the one constant is change. And
yes.
I think it's happening more now so than ever. And I look forward to it. So, you've talked, David, an awful lot about optimism. And so I always like to wrap these sessions with kind of a final call of wisdom, but perhaps we'll spin it a little bit and maybe just a final call for optimism in healthcare and in what we're doing.
So there's a great line, I think, in the Bible is without the vision, the people will perish. Yeah. So I think really giving people a vision, a clear articulation of where we're going. And the second thing is it's always difficult. There's a very famous book by a guy called Nick Timmins who wrote the story of the NHS. And he said, I think it's on a particular, something like the 5th of July, 1946, the NHS created, and on the 6th of July, it fell into its first crisis. So, I come back to what we do. It really matters, but it's really complex and nobody has got an answer. And so I just think, but I come back to it matters. It's complex. We care about it. And so there is something about as leaders remaining relentlessly optimistic about this and making those difficult decisions along the way. And the expression I use, I don't know if it's a metaphor that crosses the pond, but you don't make an omelette without breaking a few eggs, is what I would say. But what you've got to keep an eye on is the eggs to omelette ratio. That's what I say. Keep an eye on the ratio of eggs to each omelette.
Fantastic. I love it. David, thank you very much. First for your partnership over the past several years, but then also your time today and your insights. I've thoroughly enjoyed our conversation.
Yeah, me too. It's been great to meet you. As I say, thanks for inviting me along. It's been fun.
Excellent. Well, thank you.
Thanks for listening to the CereCore Podcast. We hope you enjoyed this conversation. Follow us on your favorite podcast platform for more episodes. Connect with us on LinkedIn. Visit our U.S. website at CereCore.net. And for those abroad, visit CereCoreInternational.net. Learn more about our services and find resources. At CereCore, we are healthcare operators at heart and know the difference that the right IT partner can make in delivering quality patient care 24/7. Let's help make IT better. Here's to the journey.